خالد يا خالد
دكتور جون معاك.
شايفين السكرين؟
ايوه السكرين از فول ناو كلير.
اوكي رح بلش او ننطر شوي شو بدك؟
لا بلش عادي نبدأ.
Okay. What I'm going to be talking about is simple. It's the anatomy of the upper extremity. Maybe I'll dwell a bit on the lower extremity if we have time. I would like to be honest with you. I've obtained a lot of my information in this lecture from Miller, from Netter, from Schuler, and all people involved in examinations, so as to make you acquainted with what type of questions and what you should know about the anatomy. And that's it. I'm going to begin now. One of the first and most important aspects of anatomy of the upper extremity is the brachial plexus. لازم تاخدوا a screen على the brachial plexus, على الcords, على trunks, at the terminal branches, draw it on a paper and practice on what types of nerves supply each of the muscles, because we ask a lot of questions on the brachial plexus. Even though many of us don't remember certain parts of the brachial plexus, but for exams, it is very important. The brachial plexus is a network of nerves formed by the anterior rami of the lower four cervical nerves and first thoracic nerve. If they ask you, you should mention that the branches of the brachial plexus comes from C5, C6, C7, C8, and T1. This plexus extends from the spinal cord, spinal cord, to the cervical axillary canal, يلي قبل الارmpit. It exits in between the scalenus anticus and medius to the arm. So it exits from the cord to the armpit. It supplies the afferent and efferent nerve fibers to the chest, the shoulder, the arm, the forearm, and hand. Never forget this. The brachial plexus is divided into 5 roots, 3 trunks, 6 divisions, 3 anterior and 3 posterior, 3 cords, and 5 branches. These are what you should draw. You should draw these roots, the trunks, the divisions, and with time you draw the branches that come out, and you will never forget them. There are 5 terminal branches and numerous other pre-terminal or collateral branches, such as the subscapular nerve, the thoracodorsal nerve, and the long thoracic nerve to the serratus anterior, the thoracodorsal nerve to the latissimus dorsi, and these leave the plexus at various points along its length. بدكم تعرفوا من وين بيظهروا هول لحتى they supply these structures. The subscapular nerve also supplies the subclavius muscle. The 5 roots are the 5 anterior primary rami of the spinal nerves after they have given off their segmental supply to the muscles of the neck. The brachial plexus emerges at 5 different levels, and these come out. Branches C5, C6, C7, C8, and T1. I'm going to bore you. These join and they start forming the brachial plexus. As they emerge, you have the preganglionic and the postganglionic. And this is very important. One of the questions we ask, if you have a lesion in the preganglionic region, what's the prognosis? Which one is worse, the pre or the post? Of course, the preganglionic is worse. And even if you try to do surgery, the result is not good. So keep this in mind. C5 and C6 merge to establish the upper trunk. C7, the middle trunk. C8 and T1 merge to establish the lower trunk. It's very easy. فكروا فيها. C5, 6, upper trunk. C, what? C7 is the middle trunk, and C8, T1 is the lower trunk. I know in your hearts you're laughing, ha, ha, ha. It's not easy, it's difficult. You have to put in mind that you have to remember this. This is the basics of questions that we ask. Prefixed or postfixed formations, in some cases, involve C4 or T2. These are exceptions. إذا سألوكم question في شيء غير branches بيعطوا أوقات بدكم تقولوا C4 and T2. Now, the dorsal scapular nerve comes from the superior trunk. And what does it do? It supplies the rhomboidus major and minor muscles. And these retract the scapula, and downward is the direction in which the scapula is rotated. So it retracts the scapula, and there is a downward force on the scapula, secondary to the nerve supply of the scapular nerve, of the muscle, which is the rhomboidus major and minor. The subclavian nerve originates in both C5 and C6, and it innervates the subclavius muscle. And this is involved in lifting the first ribs during respiration. The long thoracic nerve, which arises from C5, 6, and 7. It supplies the serratus anterior, which draws the scapula laterally and is the prime mover in all forward reaching and pushing actions. Trunks. These roots merge to form the trunks. The superior or upper, C5, C6, the middle, C7, and the inferior or lower, C8, T1. The divisions. Each trunk then splits into 2 to form 6 divisions. Yeah, Shabab, I know it's difficult. I know when you see it, شو بده يحفظوا تحفظوها. قرية على شكلت 4 مرات تحفظوها. The anterior divisions of the upper, middle, and lower trunks, and you have the posterior divisions of the upper, middle, and lower trunks. When observing the body in the anatomical position, the anterior divisions are superficial to the posterior divisions. The cords. These 6 divisions regroup to become 3 cords or large fiber bundles. The cords are named by their position with respect to the axillary artery. Yella anterior, anterior, yella posterior, posterior. The posterior cord is formed from 3 posterior divisions of trunks C5, C8, T1. يعني كل واحد divides in half and of the trunks, and they join to form the posterior cord. The lateral cord is formed from the anterior divisions of the upper and middle trunks, C5-7. The medial cord is simply a continuation of the anterior division of the lower cord, lower trunk, C8-T1. Finally, هيدي الصورة اللي لازم تاخدوها. أنا أعطيكم اللكشة تبعي كاملة. تاخدوا هالصورة بتعملوها وبتقعدوا بتحفظوا عليها. أنا بعد لهلا لما بدي أتعلم شيء على البراكيال plexus بروح لهالصورة. I see where you can see where are the roots, where are the trunks, why did they join, what joined to form the trunks, the upper, the middle, and the lower. Then you see that each one is dividing into half, and they're forming a division. They unite. Three unite to form the posterior cord, the lateral cord. You have 1 and 2, which is C5, C7, and you have the medial cord, which continues as such. So you have to keep this in mind. The branches are listed in the following tables. Most branches arise from the cord, but few branches arise directly from earlier structures, meaning from the trunk and the division. So the 5 on the left are considered terminal branches, which I will be showing in the slides. These terminal branches are the musculocutaneous nerve, the axillary nerve, the radial nerve, medial nerve, and ulnar nerve. These are our important nerves that we deal with. Due to both emerging from the lateral cord, the musculocutaneous nerve and the medial nerve are well connected. At times, you see there's a connection of nerve tissue between these two nerves. So you have to think, and there is a connection between the median and ulnar and the forearm, which is called Martin Gruber lesion. They are connected. At times you get a palsy of one nerve, and yet you still have function of that nerve to the muscles. Why? Because of the connections. The musculocutaneous nerve has even been shown to send a branch to the medial nerve, further connecting them. So you have, this is very important, and there have been several variations reported in branching pattern, but these are very rare. You have to keep this in mind that it does occur. Now, what did I speak about? I have this table. This table, in my mind, is very important. You have the dorsal, let me see. You have the dorsal scapular nerve, and these are C4-5, and these supply the rhomboid muscles and the levator scapulae. This table you should remember. You have the long thoracic nerve, which we spoke about, C5, C6, 7. It supplies the serratus anterior. You have, you know about the diaphragm. The diaphragm receives its nerve supply from C3, 4, 5. We spoke about the nerve to the subclavius. It comes from C5, C6 to the subclavius. What does the subclavius muscle do? It elevates the ribs during inspiration. Upper trunk, suprascapular, we know it gives the supplies the supraspinatus and the infraspinatus. You have the lateral cord, the lateral pectoral nerve, which supplies the pectoralis major, minor, and you have to keep this in mind. Finally, you have the musculocutaneous, which supplies the biceps, the brachialis, and the coracobrachialis. So you have to pay attention. These are the muscles. And you know that the musculocutaneous nerve is what we have to look after to prevent injury when we're doing a letter J procedure. So you have to you have to know your anatomy to do good surgery. So you have to know all these nerves. You have to look at this table and remember well. Don't forget that the thoracodorsal nerve supplies the latissimus dorsi. Don't forget about the lower subscapular nerve, which supplies the subscapularis, which is very important for us. Why? Because if it's damaged, we have weakness of internal rotation. We don't have a proper lift off. We don't have a proper abdominal press test. I want you to when you're sitting and listening to me, you should say, what is the abdominal press test? What is the lift off test? These are questions we ask in the examination. What about the posterior cord? You have to know what muscles it supplies and where is the sensory supply of this muscle. Okay, please don't forget this. عم بدي شيء من الدرب اجا وعم بيعذبني. يلا ماشي الحال. What can I do? طيب. And likewise, all the nerve supplies to muscles, you have to know them. You have to memorize them. This will take you a good 2 hours to memorize. And I'm sure you will do good. Okay? Now, what about function? The brachial plexus provides nerve supply to the skin and muscles of the arms with 2 exceptions. The trapezius muscle is supplied, don't forget, by what? The central nerve 11, by the spinal accessory nerve. And this is important for you to know. And it supplies the skin. In addition, you have a supply of the skin in the axilla by the intercostal brachial nerve. These are not within the brachial plexus. If we ask a question, what 2 areas, let's say not muscles, what, because we cannot specify muscles, skin, what 2 structures are not supplied by the brachial plexus? You should say the trapezius muscle, which is by the spinal accessory nerve, and you should say about the skin near the axilla is by the interbrachial nerve. The brachial plexus communicates through the sympathetic trunk via gray rami, communicants that join the plexus root. The terminal branches of the brachial plexus, namely the musculocutaneous, the axillary, the radial, the median, and ulnar nerve, all have specific sensory, motor, and proprioceptive functions. This is a summary of what I have been telling you. You should know the musculoskeletal table. You say musculocutaneous, brachialis, biceps, coracobrachialis, axillary nerve, deltoid, and teres minor. The radial nerve, posterior aspect of lateral forearm and wrist, triceps, brachii, brachioradialis, anconeus, etc., etc. And the median nerve, it supplies the medial 3.5 fingers sensory-wise, and it supplies also the muscles of the thenar and of opposition. So pay attention. The only muscle not supplied by the median nerve in the thumb is what? The adductor pollicis. And if the adductor pollicis is gone while you're doing opposition, you get the Froment sign. You should know what is the Froment sign. You should know about the skin on the medial aspect of the hand, which is supplied by the ulnar nerve. You should know that the interossei are supplied by the ulnar nerve. You should know that the lumbricals 3 and 4 are supplied by the ulnar nerve, while 1 and 2 supplied by the median nerve. All these are very important. Don't forget about the adductors of the thumb. Don't forget about the forearm flexors. The hypothenar eminence is ulnar, so don't forget these. The shoulder girdle includes 3 bones: the scapula, the clavicle, and the humerus, and 3 joints: the glenohumeral, the acromioclavicular, and the sternoclavicular joints. The scapulothoracic articulation is also considered part of the shoulder girdle. This is something very important that you should remember. For every 2 degrees of glenohumeral motion, approximately 1 degree of scapulothoracic motion occurs. Don't forget this. This is a question we ask. Okay? And I would tell you, speaking about the rotator cuff muscles, they stabilize the shoulder within the glenoid in the first 15 to 30 degrees, and then while it's stable, the deltoid comes into play. So don't forget these. As a result of this coordinated movement, the shoulder has a greater range of motion than any other joint in the body. The scapula is a triangular, flat bone that is surrounded by muscle. Its curved coracoid process projects anteriorly. I'm sure you all have done lethargy procedures and you know everything about the coracoid. It projects anteriorly from the superior border and is the site of origin for the coracobrachialis, as we spoke so much about, and the short head of the biceps muscles. So pay attention to this. This is important. These muscles are attached. When you take the attachment and transfer it laterally, you're increasing what? The amount of stress that will produce an anterior force to prevent anterior dislocation of the shoulder, plus putting it as a bone block. So you have 2 functions when you do a lethargy that is prevented. You transfer the coracoid process more laterally, and you use it as a block at the inferior aspect of the glenoid, the anterior inferior, because this is the site where we get the dislocation in most of the cases and where a lethargy is indicated. So look at what I'm saying. The coracoid is placed anterior. The acromion is posterior. You have the clavicle, which is S-shaped, forms a joint, which is the acromioclavicular joint. You have to know about the anatomical neck boundaries. You have to know about the surgical neck boundaries. You should know how much the proximal humerus is retroverted, which is 20 to 30 degrees, especially when you're doing a reverse shoulder. You should know how much retroversion exists in the pear-shaped glenoid, which is 5 degrees. So don't forget, the glenoid is retroverted 5 degrees. The proximal humerus is retroverted 20 to 30 degrees. You should know where the muscle insertions are. You should know where the pectoralis major is. You should know where the pectoralis major, the latissimus dorsi, and the teres minor tendons are inserted. You should know that the subscapularis inserts on the lesser tuberosity, and you should know that the long head of the biceps exist in between the greater and lesser humerus. This shows you the anatomical structures that I spoke about. You should know about the ligaments. You should know about the coracoacromial ligament and its significance in taking part in preventing the shoulder to migrate proximally. You should know about the trapezoid and the conoid ligament, which is this between the coracoid process and the inferior aspect of the clavicle. You should know which one is lateral and which one is medial. Is the trapezoid lateral or is it the conoid? The way I remember it, I say T is lateral, T, trapezoid, while conoid is medial. So remember these anatomic structures. The other notable scapular prominence is the acromion, a spine-like process on the posterior aspect, as I told you, and you should never forget about the coracoacromial ligament, and we should never attempt to dissect this or resect it or cut this, as it stabilizes the humeral head in the superior direction. The two coracoclavicular ligaments prevent the clavicle from riding superiorly, which are the trapezoid and conoid. The clavicle is an S-shaped tubular bone that articulates with two joints, the sternoclavicular medially and the acromioclavicular laterally. The proximal end of the humerus includes the humeral head, the greater and lesser tuberosities, and the humeral neck. The head of the humerus, as I mentioned, is retroverted 30 degrees. Don't forget that the scapula is also a glenoid. The pear-shaped glenoid is retroverted around 5 degrees. Don't forget that the glenoid is surrounded by a labrum. Why? Because the head of the humerus is larger than the glenoid. So the glenoid labrum, which is a fibrocartilaginous structure, tends to deepen the glenoid and increase the stability of the head within the glenoid. And if it helps in creating a negative pressure, yani, it's sticking the head within the glenoid as the deltoid is preparing to function. And these muscles that help in it are the rotator cuff muscles. Never forget these. These are very important. They create stability to the shoulder. This is a diagram that shows. إذا بتطلعوا بالنص بتلاقوا إنه الجلينويد is pear shaped مثل النجاسة. It's pear shaped. حواليها عندك الجلينويد. Why? This is flat. The head is large. If it's alone, it won't hold well. So we need the glenoid labrum that deepens it, and we need a negative pressure that will hold it in place. These are surrounded by ligaments. عندك the superior, the middle, and the inferior glenohumeral ligaments. These help in stabilizing the capsule, plus the muscles that surround it. So don't forget this. The deltoid is a large, powerful muscle whose primary function is shoulder abduction. The anterior half of the deltoid elevates, meaning that it flexes the shoulder, and the posterior half provides extension. So the posterior half of the deltoid is involved in extension. Underneath the deltoid are 4 rotator cuff muscles. The subscapularis, this is located anteriorly. The supraspinatus is located superiorly. And the infraspinatus and teres minor muscles are located posteriorly. So you can see it's surrounded by these muscles. These create not only motion, it creates stability. It protects the humeral as humeral glenoid joint. The deltoid provides most of the power in the shoulder motion, whereas the rotator cuff muscles act as a force couple to fine-tune and enhance the efficiency and stability of shoulder motion by compressing, depressing, and thus maintaining the humeral head in the glenoid fossa. Other important shoulder muscles include the trapezius, the latissimus dorsi, the serratus anterior, and the pectoralis major. The subclavian artery passes under the clavicle and continues as the axillary artery as it traverses the anterior aspect of the shoulder joint. Anastomosis of branches of the axillary artery provide important collateral circulation to the upper extremity. This shows you the artery. The subclavian, how it becomes the axillary artery, and how it gives the branches. It gives the anterior circumflex humeral, the posterior circumflex humeral. It gives the anterior circumflex humeral, gives you the arcuate artery, which goes through the intertubercular groove, and it supplies 38% of circulation to the head. In the past, we used to think that it is the major blood supply to the head. Now we know it's not. It's the posterior circumflex humeral, which supplies between 60 and 62% of the head. So Hertel was good in certain regions, but not in all. Okay, now in addition, when you go posterior, you see that the triceps, the long head, and the lateral head, they arise from the scapula and the humerus together. These, in addition, give protection. And you have the triangular foramen, and you have the quadrilangular foramen. You have to know these. You have to know the nerve supply, where it's coming out together with the blood supply. So we spoke about 38%. The nerves about the shoulder include the brachial plexus and its terminal branches, the sympathetic nerves, the supraclavicular nerves, and the cranial nerve 11. We spoke about these. Now, important posterior landmarks include the quadrangular space and the triangular interval. The quadrangular space is bordered by the long head of the triceps, the surgical neck, meaning bone, of the humerus, the inferior border of the scapula, and the teres major. So what passes through them? What do we know? It's the axillary nerve and the posterior humeral circumflex artery. These pass through the space. This is another question we like to ask. So please pay attention. The triangular interval houses the radial nerve and the deep brachial artery. Its borders are the teres major, superior, the long head of the triceps medially, and the lateral head of the triceps laterally. So know the boundaries of the quadrangular space and triangular space, and know what structures pass through them. This is important from the anatomical aspect. A bit about the physical examination. You should begin the physical examination with an inspection of the patient's overall posture and alignment of the shoulder. Look for swelling. Look for ecchymosis, which may indicate recent trauma. Note areas of muscular atrophy, suggestive of nerve dysfunction. Injury to the cranial nerve 11 results in atrophy of the trapezius muscle. If you know the nerve supply, then you can say what is occurring, which is seen superiorly as a reduced neck to shoulder contour. You see that there's a dissymmetry. The supraspinatus nerve dysfunction causes loss of normal posterior shoulder contour and prominence of the scapular spine and the crown. We know that the nerve, the suprascapular nerve, which supplies the supraspinatus and the infraspinatus, passes through the suprascapular notch. At times, you can have sclerosis or injury or fractures that kink this foramen, and the nerve is injured. And as a result, you have atrophy of both the supraspinatus and infraspinatus. Or this nerve can pass through this canal, everything is normal. As it comes to the spinoglenoid area, you can have a ganglion or any injury or whatsoever, which narrows this area, which is present between a ligament and the area between the glenoid and the spinous process. This will press on the nerve and it will supply the infraspinatus alone. So the supraspinatus is intact while the infraspinatus is gone. So you have to know, if they put your patient, if they ask you, is the supraspinatus is intact, where is the block? You tell them in the spinoglenoid region. If both are gone, it's at the suprascapular region. So don't forget this. Palpate the subcutaneous landmarks to detect deformity or tenderness. For example, with an acromioclavicular separation, the distal end of the clavicle is prominent. Start at the sternoclavicular joint and proceed laterally along the clavicle to the acromioclavicular joint. Proceed to the lateral edge of the acromion and the greater tuberosity of the proximal humerus. Also, palpate the long head of the bicep that lies in the bicipital groove of the proximal humerus between the greater tuberosity and lesser tuberosity to detect whether subluxation is occurring or tenderness secondary to inflammation or tendinitis. So keep this in mind. Shoulder range of motion is assessed in 4 planes. The zero starting point is with the arm at the side of the body. Flexion is better described as total elevation is maximum upward movement. Slight external rotation and abduction are required to reach the maximum elevation. Why? Why? Did you ask why? ليه لما الواحد بده يرفع ايده ما بيقدر يرفع كل المجال إلا ما external rotation. Why? Because the greater tuberosity will impinge on the acromion, and this would limit further elevation. So keep this in mind. It's common sense. This is testing the shoulder range of motion, inflection, and abduction. This is how we do them. Abduction is maximum movement in the coronal plane, Normal flexion and abduction occur at 160 to 180 degrees. External rotation may be measured with the arm at the side or abducted to 90 degrees. The degree of internal rotation is the highest midline posterior spinous process reached by the extended thumb. This shows you of how you can measure in abduction, can measure the amount of external rotation, internal rotation on the extreme right side. And this would tell you whether the patient has a lift-off test, meaning that the wrist, he can elevate it off from the back of the body, the thorax. It indicates that the subscapularis is intact. In young adults, internal rotation typically goes beyond the inferior tip of the scapula, approximately the T7 spinous process. Any difference in active versus passive motion, as well as in the quality of movement, should be noted. For example, patients with instability or rotator cuff inflammation may have a dysrhythmic motion. Patients with عم تفهم عم تاخذوا في شي كومنت؟ خالد في شي كومنت؟ خالد في شي كومنتس بدكم تعطوها؟ Are there any questions? Am I clear?
ما في أي كومنت يعني من ناحيتنا لا. حسن في سؤال يا شباب.
Am I clear؟ عم بوضح لهم.
Very clear.
عم جرب وضح لهم قد ما بقدر.
لا كل شيء واضح. اوكي.
يا شباب خليني اقول لكم شغله مهمه. انتبهوا، روحوا افتحوا الكتب. ماشي قلت لكم من محل اخذهم، في كتير اخذهم انا نقل بس لحتى اقدر افسر لكم اياها. هول بيجوا بالفحص بالاورال. لان نفحص الكتب نقول له للكانديديت فحصوا الكتب قدامنا. How would you measure for flexion, abduction, external rotation, internal rotation? What is the abdominal press test? What is the lift-off test? We ask these questions. These are basic. مشان هيك ليه please روحوا على بيتكم، سووا العيلة، فوتوا على أوضة، سكروا الباب واحفظون، لأن هولي ما بتحفظون كيف ما كان. Please listen to what I'm trying to tell you. بدنا نجاح 100% بالفحص يا شباب. Now, patients with a rotator cuff tear commonly have a shoulder shrug during abduction. ليش؟ لأن they want to elevate or initiate abduction. That's why they shrug it. Why do they shrug it? مثل بيرفعوا الكتف في الرفع. In patients with adhesive capsulitis or arthritis, internal rotation may be limited to the sacrum or lumbar region. Assess the deltoid muscle strength with the shoulder in 90 degrees of abduction. To isolate the anterior deltoid, move the arm forward. Do the reverse to assess the posterior deltoid. The supraspinatus muscle is tested with the shoulder in 90 degrees of flexion and the arm internally rotated and slightly abducted in the plane of the scapula. The external rotation strength of the infraspinatus and teres minor is tested with the patient's arms at the sides and externally rotated approximately 30 degrees. To test subscapular strength, internally rotate the arm behind the back, فرجيتهم إياها بالصورة, to the lumbosacral level and ask the patient to lift the arm off the back and away from the back against resistance. Examination maneuvers that may elicit pain are performed last. So you have the Hawkins sign, you have the subacromial impingement signs, is by lifting the arm up and internally rotating. This will impinge the greater tuberosity on the acromion if you have an impingement condition, and the patient will have pain. This is the lift off test. يا جماعة ما تنسوها. This is the lift. We put resistance from behind. This is not shown in the picture, but we put resistance. This is the abdominal press test or the belly press test, again for the subscapulars. It tells us whether it's intact or not. Okay, so don't forget these points. Keeping the scapula stabilized, depressed while elevating the arm with the shoulder internally rotated causes the supraspinatus tendon to impinge on the anterior inferior acromion. Another technique is demonstration of pain with shoulder flexed to 90 degrees, the elbow flexed to 90 degrees, and then moving the shoulder into internal rotation. Hail Hawkins. So you have to pay attention. This is what we ask. How would you develop, how would you demonstrate impingement of the greater tuberosity on the acromion, where you have 3 types of acromion, 1, 2, and 3, depending on it. So you have to know a bit about the shoulder. This is how we do to diagnose impingement. We internally rotate the humerus at 90 degrees and 90 degrees of flexion. And you see that the patient will complain of pain. Arthritis in the AC joint is suggested when cross-body adduction, adduction, that is flexing the shoulder to 90 degrees and then adducting the arms. This elicits pain. You see in the photograph, you see that there is arthritis. You want to demonstrate it. You ask the patient to flex 90 degrees, internally rotate, and then adduct. You're bringing the acromion on the clavicle. It is rubbing. The patient will have pain. Patients with anterior instability may have a positive apprehension test. That is, they express apprehension and a sense of instability when the shoulder is placed in 90 degrees abduction and then maximum external rotation. Elbow and forearm. Anatomy. The elbow is a functional link for positioning the hand in space. A fulcrum for the forearm lever and a load-carrying joint. As such, it requires a combination of mobility and stability. The 3 articulations of the elbow provide flexion and extension, as well as forearm rotation. This is the elbow joint. You can see you have a coronoid fossa. Behind, you have the olecranon fossa. You have the trochlear notch. You have the head of the radius, you have the capitellum. These are three structures that we concentrate on in the elbow joint. Of course, you have to know about the medial epicondyle, and you should know about the canal that the ulnar nerve passes through. So you have to pay attention to these points. This is a lateral view showing you all these in detail. Control and stability of flexion and extension are provided primarily through the ulnar, humeral, trochlear, and olecranon joints, articulations, and secondary through the radiohumeral, capitellum, and radial head articulations. So pay attention. Stability depends on these. The trochlear is shaped like a spool and fits in the wrench shaped trochlear notch. يعني موجود العزق بقلبه. It creates stability. Any fracture or disturbance will promote instability if not properly treated. This anatomic configuration, in conjunction with the collateral ligaments, namely the medial and the lateral collateral ligaments, provides a stable hinge joint that can lift heavy objects. Rotation of the forearm occurs through the proximal and distal radio-ulnar articulations. Distal to the radial head, the bone tapers to form the radial neck. Then it flares at the radial tuberosity. I want you to keep this in mind, the radial tuberosity. This is where the biceps tendon inserts. When it's avulsed from there. Keep this in mind. And another point to keep in mind is to remember that there is an interosseous membrane in between the radius and ulna. This interosseous membrane can be damaged or torn in fractures. You have to keep this in mind. And this will give you problems, especially when you have the head of the radius fractured, comminuted. The whole radius moves proximally. And what happens? You won't have pain mainly at the elbow. You'll have it at the wrist because the distal radio-ulnar joint is disturbed. Keep this in mind, please. Okay? So, remember that the interosseous membrane is a thickened ligamentous structure that connects the two bones in a manner that provides stability while allowing forearm rotation. I like this picture because it shows details. It tells us about the notch. It tells us about the sploon. It tells us about how the olecranon fits on the distal end of the humerus. It tells us about the annular ligament, how well it's holding around the neck of the radius. You have to keep these points in mind. Muscles that cross the elbow anteriorly include the elbow flexors and the flexor pronator forearm muscles that originate from the medial epicondyle. In the forearm, the volar muscles are arranged in 3 layers. The superficial group includes the pronator teres, the flexor carpi radialis, the palmaris longus, and the flexor carpi ulnaris. Let me tell you, this is a question. It's a silly question, but it's nice to know. You have and the question is asked, what structures are localized, superficial, in the forearm? You have to think on the flexor aspect. the pronator teres, the flexor carpi radialis, the palmaris longus, and flexor carpi ulnaris. Then you have the deep structures. You have this is showing you them. Then you have the deep structures. Now, what I'm speaking about are on the left-hand side are the superficial structures, namely the pronator teres, the flexor carpi radialis, the palmaris longus, the flexor carpi ulnaris. These are the superficial structures. The middle layer is the flexor digitorum superficialis, and the deep layer comprises the supinator, the flexor digitorum profundus, the flexor pollicis longus, and the pronator quadratus. The flexor pronator muscle group primarily provides wrist flexion and forearm pronation. The biceps is the secondary flexor of the elbow, and it's a strong supinator. It's second, it's common sense. When it comes, inserts on the biceps tuberosity, it's a strong flexor, and as it flexes, it supinates the forearm. Immediately deep to the biceps lies the brachialis muscle, the major flexor of the elbow, and this inserts on the anterior aspect of the ulna. Now, the posterior elbow muscles include the elbow extensors, the wrist and finger extensors, and supinator. Posterior forearm muscles are arranged in two layers. The superficial group originates from the common tendon at the lateral epicondyle and includes a lateral component, the brachioradialis, the extensor carpi radialis longus, the extensor carpi radialis brevis, and a medial subgroup, extensor digitorum, extensor digiti minimi, extensor carpi ulnaris, and anconius. The deep posterior forearm muscles are the supinator, the abductor pollicis longus, the extensor pollicis brevis, and the extensor pollicis longus. The brachial artery, the main artery of the arm and elbow, travels in the anterior compartment of the arm adjacent to the median nerve. Proximal to the elbow, it gives off collateral circulations that help form a rich plexus of vessels around the elbow. At the level of the radial head, the brachial artery bifurcates into radial and ulnar artery. The ulnar artery enters the forearm posterior to the pronator teres, whereas the radial artery travels between the brachioradialis and the supinator muscle. The median nerve enters the forearm between the humeral and ulnar heads of the pronator teres. So don't forget, the pronator teres, the median nerve, enters between the two heads. Posterior to the pronator teres is the ulnar artery as it's going into the forearm. So you have the median nerve entering between the both heads of the pronator teres. The ulnar artery deep to the pronator teres. Don't forget this. Don't forget that the radial artery goes into the forearm between the brachioradialis and the supinator. The anterior interosseous nerve branches innervate the index and sometimes the long finger component of the flexor digitorum profundus, the flexor pollicis longus, and the pronator quadratus. Okay, so don't forget this. Because of the location of fibers in the median nerve, isolated paralysis of the anterior interosseous nerve may occur with an elbow fracture. The rest of the median nerve innervates all the volar forearm muscles, except the ulnar half. The ulnar half, don't forget this, the ulnar half of the flexor digitorum profundus, which is the fourth and fifth fingers, and the flexor carpi ulnaris. So both these are supplied by the ulnar nerve. The rest of the forearm muscles on the flexor type on the anterior part of the forearm are supplied by the median nerve. Don't forget that the ulnar nerve supplies the medial half of the profundus to the third and fourth fingers, while it also supplies the flexor carpi ulnaris. Please, I beg you not to forget this. What about sensation? We know that the median nerve, this is a basic question, is that it supplies the lateral and 3.5 fingers sensation-wise. And this is shown in the blue area. The ulnar nerve exits the anterior compartment of the arm, passing behind the medial epicondyle through the cubital tunnel at the elbow, and then enters the forearm between the two heads of the flexor carpi ulnaris. It innervates the flexor carpi ulnaris muscle, the ulnar half of the flexor digitorum profundus muscle, and ultimately the intrinsic muscles of the hand, like the interosseous and the hypothena muscle. This shows you that the ulnar nerve provides sensation to the medial 1.5 fingers, and to the small and half of the ring fingers. In the arm, the radial nerve travels within the posterior compartment and then enters the anterior compartment lateral to the humerus. In the antecubital fossa, the radial nerve innervates the brachioradialis and extensor carpi, radialis longus, before dividing into superficial sensory and deep, mostly motor branches. This shows you the anatomy of the radial nerve. So, I repeat, you have to know this. And whoever is calling me to call me later after the time, 7 o'clock, because I have a meeting and I'm giving a lecture, Firas. Please, can you tell also Ramsey? I beg you. Yalla, bye-bye. The superficial radial nerve provides sensation to the radial dorsal wrist and hand. The deep branch innervates the remaining extensor muscles of the forearm. It travels deep and through the supinator muscle and exits this muscle as the posterior interosseous nerve. Distal to the radial tuberosity, the deep branch of the radial nerve may lie on the bone and as such is vulnerable to injury in fractures of the proximal radius or in operations at this site. Physical examination. Let's take a 5 minutes break and carry on. Okay, Khalid? Khalid.
دكتور جون
خلينا نرتاح
يا
5
دكتور جو.
دقائق. 5
خلاص حاضر
دقائق.
ايوه. ارتاح ايوه ارتاح.
في شغلي بدي اسالك. Are they
أيوة.
understanding؟ عم بيفهموا ان شاء الله، ما يقولوا لي ايه.
انا ان شاء الله بيفهموا. شوف دكتور جون، هو هذا السبجكت هم بيروها من قبل يعني، وهو ريمايند لهم وبذاكر يعني متابعين كويسين يعني تمام، بيستفيدوا اكيد.
ليك خالد عم جرب فسر لهم على قد ما ممكن يعني.
لا كويس يعني تمام يعني، هو ريمايند لهم كويس، لانه هاي بينسوها يعني دائما، لازم ريفيو لها. ايوه.
Great.
Thank you very much. خلاص take rest 5 minutes.
5 minutes. سمعني خالد؟ سمعني يا خالد؟
يا دكتور جون. ايوه سامعك دكتور.
اوكي يلا رح برجع بلش.
يلا نبدا.
يلا. Okay, one should inspect the elbow for swelling and ecchymosis and determining the carrying angle. The carrying angle is important. It helps us in arriving at a diagnosis following trauma. The axial alignment of the humerus and ulna with the elbow when the elbow is extended. You have to remember that the normal carrying angle is 10 to 20 degrees, with most studies observing slightly greater cubitus valgus in females. If we ask this question, keep it in mind. Angular deformities may occur secondary to previous trauma, growth disturbances, or genetic syndromes. So pay attention. So you should realize how much your angular deformity is to arrive of whether the patient has trauma, growth disturbances, or a genetic syndrome. Because all these disturb the angular alignment of the elbow. Ecchymosis, swelling, or both about the elbow indicate a muscle or tendon injury, fracture, or elbow sprain or dislocation. Palpate subcutaneous landmarks for sites of tenderness, deformity, or effusion that indicate the site of occult fracture, tendinosis, ligament sprain, or tendon rupture. From lateral to medial, the structures in the antecubital fossa are the biceps tendon, the brachial artery, and the median nerve. A palpable defect is key. I repeat, it is key to diagnosing rupture of the distal biceps. You can see it. You can even grab the tendon of the biceps in patients who have an intact tendon. But if you put your finger around a tendon that is torn, you feel that it is void, and it will tell you that is a disruption. Rarely you can have ruptures of the triceps tendon. Joint effusion is best detected in soft spots between the lateral epicondyle and the radial head and olecranon. This is the soft spot that we choose. This triad, lateral epicondyle, the radial head, and the olecranon. This is a soft spot. Don't forget this. You can, if you have an infection, you can aspirate from here. Tenderness over the radial head or humeral condyles may indicate an occult fracture that is not visible on radiographs. The zero starting position for measurement of elbow motion is a straight extremity. Young children commonly extend the elbow to 10 to 15 degrees, but adults usually cannot extend the elbow past zero starting position. The normal range of elbow flexion is from 0 to 145 degrees. The plane of forearm rotation is pronation supination. Pronation literally means the state of being prone, or as it relates to the forearm, the palm being backward. The palm being backward. Okay? Being turned backward. I repeat, the palm being backward is pronation. The palm turning forward is supination. I repeat, supination, pronation, and each is 90 degrees. In the forearm, rotation measurement, the patient's arm is stabilized against the chest wall, and the elbow is flexed to 90 degrees. The zero starting position occurs with the thumb aligned with the humerus. Normal motion in adults is 75 degrees pronation and 85 degrees supination. Mild elbow contractions are of limited functional consequence, as most activities of daily living are accomplished in an arc of motion from 30 to 130 degrees. So we don't use the 0 to 145 degrees. We in function is 30 to 130 degrees and 50 degrees in each pronation and supination. Now, if we pronate and supinate, it reaches nearly to 90 degrees in each action, but we don't need it. We need only 50 degrees. Anatomy and biomechanics of hand and wrist. The carpus or wrist is composed of 8 carpal bones that link the forearm to the hand. The proximal carpal row, the scaphoid, lunate, triquetrum articulates with the distal radius and ulna, as well as the trapezium, trapezoid, capitate, and hamate. Now, the pisiform is present within the flexor tendon, flexor carpi ulnaris. This shows you the bones of the hand. You should know them. You should know about the distal carpal rows. Don't forget you have the trapezium, the trapezoid, you have the capitate, and then you have the hamate. Don't forget proximally you have the scaphoid, the lunate, the triquetrum, and then you have the pisiform. So don't forget these. You have to remember them. You have to remember the glular lines on X-ray, which I will be talking about later on. The pisiform, also part of the proximal row, is a sesamoid bone in the flexor carpi ulnaris tendon that articulates only with the triquetrum. The bones of the hand are the metacarpals and the phalanges. The carpo-metacarpal joint of the thumb, you should all know that it is a saddle joint. a configuration that permits. You have abduction, you have adduction, as well as circumduction that permits opposition of the thumb to the fingers. I repeat, it permits abduction, adduction, circumduction, opposition of the thumb to the fingers. The metacarpophalangeal joint, proximal interphalangeal, the distal interphalangeal joints are all hinge joints. They undergo flexion extension. Don't forget that the carpo-metacarpal joint of the first component, the first carpo-metacarpophalangeal carpo-metacarpal joint is a saddle joint. The skin on the dorsal surface of the hand is thin and flexible to allow full flexion of the fingers, whereas the palmar surface skin is thicker and characterized by creases. The distal volar crease of the wrist crosses the proximal scaphoid and the pisiform. The distal palmar crease of the hand corresponds to the MP joint or metacarpophalangeal joint, and the proximal finger crease is at the base of the proximal phalanx. The extrinsic muscles of the wrist and hand originate on the medial and lateral humeral condyles and the proximal radius and ulna. These show you the extrinsic muscles on the extensor surface or the dorsal surface. You have certain tunnels or compartments for these tendons to pass. You have a first compartment which consists of the abductor pollicis longa and extensor pollicis brevis. This is one. Two is the extensor carpi radialis brevis and longus. Three is the extensor pollicis longus. Four is the extensor digitorum communis together with the minimi. Now, the minimi is out together with the proprius. Then you have the extensor digiti minimi, and then you have the extensor carpi ulnaris. These are all tunnels through which the tendons pass. The extrinsic extensor tendons cross the wrist, as I mentioned, and they are in 6 compartments bounded by the extensor retinacular ligament. The extrinsic finger and thumb flexor tendons and the median nerve enter the hand through the carpal canal. This is a coronal section or transverse section showing you these tunnels in which the tendons pass through. You have to look at this. You have to study this, because many times we don't put names and we'd say, insert the names of the tendons that are passing through this. The transverse carpal ligament is a thick band extending from the hamate and pisiform to the scaphoid and trapezium. This forms the ligament that covers the median nerve as it goes into the wrist. This ligament, together with the structures in it, if they're large, will promote compression on the median nerve to give us a carpal tunnel syndrome. Keep this in mind. You have to know the transverse ligament. Where is it coming from? Where is it from? The hamate, the what? The pisiform, to the scaphoid, and what else? The scaphoid and the what? I want you to know. And this tells you that it is scaphoid and trapezium. Sorry, I took the night because I wasn't sure of the trapezium. So this is the boundaries. You have to know this. This is the transverse ligament. It shows you the median nerve which lies beneath it. It shows you the Guyon's tunnel in which you have the ulnar artery together with the ulnar nerve which lies medial to the ulnar artery. You have to know about the superficial palmar arch and the deep palmar arch, of how they are formed. The intrinsic musculature includes the thenar, the hypothenar, the interosseous muscles. The thenar muscles are the abductor pollicis brevis, the opponens pollicis, and the superficial head of the flexor pollicis brevis. So don't forget this: the abductor pollicis, the opponens pollicis, and the flexor pollicis brevis. You have the interossei muscles, and you have the lumbrical muscles which arise from the profundus tendons and insert into the expansion at the proximal interphalangeal joints. The hypothenar muscles are composed of the abductor digiti quinti, the opponent digiti quinti, and the flexor digiti quinti. The dorsal interosseous, commonly referred to as dorsal intrinsics, the abductor fingers, and the palmar interossei flex the fingers, supplied by the ulnar nerve. The DIP joints of the fingers is flexed by the flexor digitorum profundus. It has a separate muscle belly for the index finger, which therefore flexes independently, but a common muscle belly for the long, ring, and small fingers, which tend to work as a single unit. The proximal interphalangeal joint of the fingers is primarily flexed by the flexor digitorum superficialis, which insert on the anterior at the base of the middle phalanx. They flex the proximal, while the distal are flexed by the profundus tendon. It has individual muscle bellies for each finger, thus providing the individual finger flexion at the PIP joint that is necessary for activities such as playing a musical instrument and typing. The flexor digitorum sublimis separates into two parts before its point of insertion, and in between them passes the tendon of the flexor digitorum profundus. You can see it. The center is the profundus, and then you have from both sides, you have the tendon inserting on the base of the middle phalanx, which is the sublimis. So you have the profundus in the center, the sublimis on both sides. This shows you it in detail. You can see over here the flexor digitorum sublimis or superficialis, and you can see here the long head and the tendon of the profundus. Both finger flexors are enclosed in a common tendon sheath. The proximity of the flexor digitorum sublimis and flexor digitorum profundus tendon to the surrounding sheath promotes efficient movement, but adhesion from injury or infection can be problematic in this region. They are famous for no man's land during trauma. You get adhesions of these two tendons. The interossei along with the lumbrical muscles, flex the MP joint, and extend the PIP joint and DIP joints. The lumbrical muscles are unique in that they originate from the profundus tendons. And if you are asked which muscle originates from a tendon, you should know that it's the lumbrical muscles. They insert into the dorsal apparatus of the antagonist extensor mechanism. This shows you of how these tendons, the lumbrical coming and extending into the, inserting on the extensor aspect of the proximal interphalangeal joint. This shows it further. The interossei and two ulnar lumbricals are innervated by the ulnar nerve. I repeat, the interossei and the two ulnar lumbricals are innervated by the ulnar nerve, but the two radial lumbricals are innervated by the median nerve. The metacarpophalangeal joints of the fingers are extended by the extensor digitorum longus, the extensor indicis proprius, and the extensor digiti quinti. When the MP joints are flexed, these muscles also can extend the PIP joint. Otherwise, the intrinsic muscles extend the PIP and DIP joints. In other words, if you're asked if the intrinsic muscles need to function, they function normally as extensors of the proximal interphalangeal joint. But if you have the metacarpophalangeal inflection, then what happens? The common extensor tendons extend the PIP joints. So they both function in extension of the PIP joints, but one in flexion and one in extension. The complex arrangement of the tendons on the dorsum of the hand provides the necessary synchrony and balance between flexors and extensors during the multiple precise motions of the metacarpophalangeal joints, PIP and DIP joints working in concert. The main insertion of the extrinsic extensor muscle tendon is through the central slit at the base of the middle phalanx. The intrinsic muscles join with the extrinsic extensors through the interdigitating transverse and oblique fibers of the dorsal apparatus to extend the PIP and DIP joints. Contraction or spasticity of the intrinsic muscles creates increased tension on the dorsal hood. Swan neck deformity develop with PIP joint hyperextension, MP and DIP joint flexion. This is a swan neck deformity of the third finger. You see that there is extension of the PIP joint. On the index finger, you see it's a boutonniere or buttonhole deformity, which is the opposite of a swan neck with the lateral bands slipping anteriorly. Laceration of the central extensor tendons, proximal to its insertion into the middle phalanx, allows the lateral bands to slip volarly and produce the opposite flexion boutonniere deformity, the French from buttonhole PIP joint deformity. The radial artery lies radial to the flexor carpi radialis tendon at the wrist. After crossing the snuff box, the radial artery passes through the first intermetacarpal space to the palm as the main contributor to the deep palmar arch, which is completed by the deep palmar branch of the ulnar artery. This is the extensor tendons, as I spoke to you about before. Likewise, the ulnar artery and nerve lie radial to the flexor carpi ulnaris and pisiform as they enter Guillaume's canal. Don't forget it's bounded by the pisiform and the hamate ligament, and you have the bony structures behind. It's a canal. It's present. You see, you have the pisiform, the hamate, and behind you have a tunnel where the ulnar artery and nerve pass. The ulnar artery is a contributor to the superficial palmar arch, which is completed by a branch of the radial artery. So you have the deep palmar arch formed by the radial. The main superficial arch is created by the ulnar artery. These show you of how the ulnar artery, both the ulnar nerve and ulnar artery, lie radial to the pisiform and the flexor carpi ulnaris tendon in Guillaume's tunnel. Okay, I want to stress something important. When we have a carpal tunnel syndrome and we are doing a release, even though the patient has a Guillaume's tunnel syndrome, at times when you release the transverse ligament, you might get improvement of Guillaume's tunnel syndrome. After traversing Guillaume canal, the ulnar nerve branches into superficial cutaneous branch that provides sensation to the ulnar aspect of the palm and the ulnar 1.5 fingers, and a deep motor branch that supplies the hypothenar muscles. The ulnar nerve then travels with the deep palmar arch, supplying all the interossei, the third and fourth lumbricals, the adductor pollicis to the thumb, and the deep head of the flexor pollicis brevis. So the ulnar nerve on the thenar side supplies two muscles, adductor muscles and half of the flexor pollicis brevis. Don't forget these, please. I forget them at times. I always remember the adductor pollicis, but at times I forget the flexor pollicis half. The median nerve supplies the remaining thenar muscles and the first and second lumbricals, and it provides sensation to the thumb and radial 2.5 fingers. Physical examination. Are there any questions? Khalid, any questions? No questions?
دكتور جون
ما عم بسمع خالد.
اسمعك دكتور جون.
ايه هلا عم بسمع.
انا عارف. يا شباب سؤال.
في شيء؟ Do I carry on?
دكتور جون.
ايه
ما في اي سؤال. الشباب يعني متابعين وعم بيفهموا يعني المحاضرة تمام.
طيب بس بدي اطلب منه يروحوا
ايوه
يقروا اليوم، يروحوا يدرسوا، يروحوا يفتحوا الكتب.
ايوه
اوكي،
اوكي
بليز
يسمعوا.
يفتحوا الكتب، لان هاللكشة بتروح على الفاضي اذا ما فتحوا الكتب اليوم. Then this is a pure memory lecture. You have to remember it. يلا رح كمل. Physical examination. Inspection of the hand for atrophy of the sena muscles innervated by the median nerve or hypothena and intrinsic muscles innervated by the ulnar nerve is routinely a must. Intrinsic muscles, when weak, they cause atrophy between the metacarpals on the dorsum of the hand. Look at the nails for evidence of pitting or signs of other systemic disorders. Palpate bony landmarks and any swelling of the osteophytes or osteophytes. At the wrist, the radial and ulnar styloid process are palpable. The radial styloid is approximately 1 centimeter distal to the ulnar styloid. The dorsal tubercle at the distal radius, commonly called Lister's tubercle, is palpable. It functions as a pulley for the extensor pollicis longus and is a marker for surgical approaches. But Lister's tubercle during fractures or rheumatoid processes can irritate the extensor pollicis longus and result in a rupture. The pisiform on the volar aspect of the wrist is a landmark for the ulnar nerve and artery. The zero starting position for determining wrist motion is the forearm in pronation and the carpus aligned with the plane of the forearm. In young adults, normal wrist motion is approximately 75 degrees of flexion and 75 degrees of extension, 20 degrees of radial deviation, and 35 degrees of ulnar deviation. One of the questions we enjoy asking is, when you look at the wrist and you examine for radial deviation and ulnar deviation, which angle is larger? Is it in ulnar deviation or is it in radial deviation? This shows you the measurement of wrist motion and finger motion, lack of finger flexion, and some thumb opposition. So don't forget that abduction or radial deviation, the angle is less than ulnar deviating, the ulnar direction. Yeah, and one is 30 degrees, the other one is 20 degrees. You should realize that how much flexion you have, but we don't use it all. You should know the difference between abduction and opposition. This is showing you a patient who has a normal hand. You can see that if the ulnar nerve is intact, and if the adductor pollicis is intact, the patient is able to reach his thumb for the base of the proximal metacarpal phalangeal joint of the small finger. You should pay attention to the amount of flexion. You should see how the position of opposition is, you should see the amount of flexion, measure the tip of the finger to the palm, and you judge and tell how much limitation is present. Finger joint motion occurs primarily in flexion-extension plane, with flexion accounting for most of the motion. The wrist should be in neutral position when the finger or thumb flexion is measured. When the wrist is flexed, the extensor digitorum communis and thumb extensors are under tension, thereby limiting finger and thumb flexion. Flexion and extension can be measured at the MP, the PIP, and DIP joints, but from a functional perspective, finger flexion is a composite movement of motion from 3 finger joints. Ask the patient to touch the distal palmar crease. In young and middle-aged adults, the fingertip should touch this crease. Lack of full finger flexion can be quantified by measuring the distance from the fingertip to the distal palmar crease, as I showed you in the previous slide, and that's it. The planes of thumb motion are flexion, extension, abduction, adduction, and opposition. Opposition is the composite of motion of the carpometacarpal joint and metacarpophalangeal joint and interphalangeal joints that is critical to daily activities. In disability ratings, opposition is valued as 50 to 60% of thumb function. So opposition is very, very important. In normal opposition, the tip of the thumb touches the base of the little finger. You can see it I showed it to you. It's involved. Okay? Like this is it, showing you of how the thumb, normal thumb opposition on the middle diagram on the right side. You can see opposition is a composite of movement of the carpometacarpal, metacarpophalangeal, and interphalangeal joints. The normal range is to the base of the little finger. Limitation of thumb opposition may be quantified by measuring the distance from the tip of the thumb to the base of the little finger. Limitations of finger flexion may be quantified by measuring the distance from the finger tip to the distal palmar crease. Normal finger flexion is a composite of flexion of the metacarpophalangeal joint, PIP, and DIP joints, and allows the finger to touch the distal palmar crease. Impaired opposition can be quantified by measuring the distance from the tip of the thumb to the base of the little finger. All thumb joints move in flexion and extension, but this range is difficult to quantify at the carpometacarpal joint. Flexion at the thumb, MP joint, is typically 50 to 60 degrees. Extension is not typically observed at the thumb metacarpophalangeal joint. Normal thumb interphalangeal motion in young adults is 55 to 75 degrees of flexion and 5 to 10 degrees of extension. To assess the strength of the wrist flexors, the most powerful of which is the flexor carpi ulnaris, resist the patient's effort to flex the wrist with the elbow flexed to 90 degrees and the thumb and fingers in the extended neutral position eliminates the action of finger flexors. To test the wrist extensors, the most powerful of which are the extensor carpi ulnaris and extensor carpi radialis, they resist the patient's effort to extend the wrist with the elbow flexed to 90 degrees and the fingers flexed, eliminates the action of the finger extensors. Yani you are directing the finger extensors to something else, okay, in extension, then you can test for wrist extension, which is a function of the extensor carpi ulnaris and the extensor carpi radialis brevis. To test the integrity of the flexor digitorum profundus tendon, hold the PIP joints in extension and ask the patient to flex the distal phalanx. To assess the flexor digitorum sublimis, neutralize the profundus tendon by holding all the fingers except the one being tested in full extension and ask the patient to flex the finger. This is a common question that we like to ask. By extending the other fingers, you're inactivating the profundus and inactivating other interconnections between the tendons, and you're only testing for the sublimis. Median nerve paralysis above the elbow causes weak pronation, wrist flexion, and an ape hand with thenar atrophy and weakness of thumb opposition. Thenar muscle strength, motor branch of the median nerve, can be evaluated by asking the patient to position the thumb in abduction as you push it into adduction. Assess sensation of the median nerve at the volar tip of the thumb. Test intrinsic muscle weakness, motor branch of the ulnar nerve, by asking the patient to abduct the index finger against resistance while you palpate the first dorsal interosseous muscle. In addition, ask the patient to pinch a piece of paper while you pull on it. This shows you a positive Froment sign. You can test, you can see whether the adductor pollicis of the thumb is intact. Okay, so don't forget this. Weakness of the adductor pollicis results in flexion of the interphalangeal joint of the thumb, the positive Froment sign. Assess ulnar nerve sensation at the volar tip of the little finger. If ulnar nerve entrapment or laceration occurs above the wrist, sensation may be lost on the dorsum of the hand. If the ulnar nerve is divided distal to the mid-forearm, all the intrinsic muscles of the hand are paralyzed except for the first and second lumbricals and thenar muscles. Lack of intrinsic muscle function to the ring and little fingers causes an ulnar claw hand or hand of benediction with the fourth and fifth fingers hyperextended at the MP joints and flexed at the PIP and DIP joints. This shows you it, okay? This is a laceration of the median and ulnar nerve results in a complete claw hand because of all the intrinsics being calm. But hand of benediction is for the ulnar nerve alone. The intact lumbricals to the index and long fingers provide enough intrinsic muscles function to prevent clawing of these digits. However, if the ulnar nerve is lacerated at or proximal to the elbow, clawing of the ring and little fingers does not occur because the flexor digitorum profundus to these fingers is also paralyzed. A distal forearm laceration of the median and ulnar nerves results in complete claw hand because of all intrinsic muscles are paralyzed, but the extrinsic flexors and extensors are intact. هيدي sorry بدي اخذ هيدا خلصنا هالسكشن بس I want to do something. Then it's a recording that I had, clear recording on the current slide on all slides. Okay, now I can go back. Okay, the nail bed. What is the nail bed? We ask questions on the nail bed and on anatomic relationships. What is the perionychium, the entire area that includes the nail and nail bed and surrounding skin. The paronychium, the lateral nail fold. The hyponychium is the skin immediately distal and palmar to the nail bed at the junction of the sterile matrix and fingertip skin. The eponychium, the dorsal nail fold, proximal to the nail plate. It adds shine to the nail. And you have the lunula, which is the white portion of the proximal nail. It is most likely created by retained cellular nuclei. Now I'm telling you, I'm showing you a nail. I'm showing you a nail bed. And you're surprised why I'm showing you this. But believe me, we ask questions related to the nail. Why? Because we'll be afraid of patient having paronychia and a phelon, and how you should evacuate pus from the base of the nail bed. And you should never use a transverse incision on the pulp of the finger. So we ask this question. We love to ask it. So know the details of the part of the nail. This is a large view. The hyponychium is on the extreme right. It's directly beneath the nail. You have the free margin. You have the nail bed beneath. You have the nail plate. You have the matrix. You have the lunula, which is the white area of the base of the nail. And you have the root and the sinus. So this, you should never make an incision transversely on the pulp of the finger. They form as a contraction that bothers the patient a lot. Sterile matrix and germinal matrix. The sterile matrix is the soft tissue deep to and adherent to the nail, distal to the lunula. The germinal matrix is the soft tissue deep to the nail and proximal to the sterile matrix. The germinal matrix is responsible for most nail development. The periosteum of the distal phalanx lies immediately volar to the sterile and germinal matrices. The distance from the extensor tendon insertion to the proximal germinal matrix is approximately 1.2 to 1.4 millimeters. The skin fascia I will not go on this. You have to look this up. You should know the tendon. You have to know about Cleland's ligaments, Grayson's ligaments, the natatory ligaments, because we do ask about that. The compartments of the forearm, you do need to know them. You should know that there are 3 compartments and where they are located, and they bound which muscles. These are the compartments. You have the dorsal compartment, volar compartment. You have a mobile wad. And these are the compartments of the hand, the thenar, the adductor pollicis, the hypothenar, 4 dorsal, and 3 the volar interosseous and carpal tunnel. The palmar spaces, you have to know about peroneal space. You have to know about the thenar space. You have to know about the hypothenar space, the mid-palmar space. All these, because these are important for infections. That's where the pus is found. And you should know that there is one bursa, or long sheath with a bursa around it in the small finger. And you should know that in the index finger, you have another, and these can connect. And they call, when you have an abscess, it's called the horseshoe abscess. You have to think about the radial and ulnar bursa. It shows you the radial, which is extending from the flexor pollicis longus, the sheath, and you have the of the ring finger. You have a connection over here, and this is called peroneus space. And this is where the pus can become localized. You have a mid-palmar and you have a thenar space. So don't forget these. You have to know about Taban carpal tunnel. I spoke to you at the beginning about Martin Gruber, which is connection between the median and the ulnar nerves in the proximal third of the forearm, proximal to the anterior intraosseous branch, or distally within the flexor digitorum profundus muscles between the ulnar nerve and the anterior interosseous nerve. It occurs approximately in 15%. I don't want you to have this. Now let's review these points. The conjoined lateral bands are stabilized by the triangular ligament, which prevents volar subluxation. The transverse retinacular ligament, which prevents dorsal subluxation. This is for the flexors and extensors to localize them. You should know about the A2 and A4 pulleys. They are the most important for biomechanical efficiency of the digital flexor retinacular system. The radial nerve of the thumb is at risk during a trigger finger. Why? Because it's more volar located. Okay, so this is something important. The lumbricals, coarse palmar. Deep to the transverse intermetacarpal ligament and past dorsal to the ligament. And you should know about each of the tendons, where they are located with respect to certain tendons, so as to prevent any injury. The ulnar nerve is medial to the and volar to the ulnar artery at the level of the wrist. بديكم تطلعوا بهاي وتدرسوها. The classic order of innervation of the posterior interosseous nerve from proximal to distal, how it supplies the muscles. The deep head of the pronator teres separates the ulnar artery and the median nerve. We know this. The interosseous membrane runs from proximal to distal. And you have to think of the Essex Lopresti lesion. There is something I want you to mention, is that how would you judge where you could put a screw in the head of the radius in case of a fracture and not disturb motion in the pronation or supination? Well, You look at this tubercle to the radius styloid, and you imagine it right up to the head of the radius. And this is the area where you can put the screw in without damaging the joint by interfering with motion. And inadequate surgical decompression of the volar compartment of the forearm is often the result of incomplete decompression of the flexor digitorum profundus and pronator quadratus, which may be anatomic subcompartments within the volar forearm. So you have to know these. And now we come to some of the questions. I will not dwell through all of the questions, but you have to go to Miller. I want you to record this. I want Dr. Khalid to record this so that you can go through some of the questions. As I mentioned, the brachial plexus is very important. You have to know which are the muscles of action and arm abduction, and these are the points. So you have to know these. I'm going through these very quickly. You have to know which nerves supply what tendons, the radial nerve, the median nerve, etc. You have to know what muscles are involved in flexion, extension of the elbow, which muscles are involved and what is the nerve supply. You have to know how much ulnar deviation and radial deviation exists, which one is more. You have to know how much extension is required, how much flexion. You should know that the radius styloid is beneath or distal to the ulnar styloid. You have to know the blood nerve supplies of each of the tendons. You have to know about opposition. You have to know of how to mention any limitation by getting a ruler and measuring the distance. For a normal opposition, the tip of the thumb should reach the base of the small finger. Inflection, of course. You have to know about the brachial plexus, as I told you. In each of the exams in the United States, they give you a picture like this, and they ask you questions concerning it. So مشان هيك لازم تاخذوا هذه الصورة تتعودوا عليها وتعرفوا شو بدهم يسألوكم. You have to know of how the brachial plexus passes from the cervical cord to the armpit. These I'm giving you them. You have to know about preganglionic and postganglionic injuries, which one is more or worse prognostic-wise. You have to know of winging of the scapula, and if the patient has Horner's syndrome, it tells you that it is preganglionic. So this is important. You have to know if you have meiosis, pupil constriction, and anhydrosis. This is the appearance from anhydrosis of how the face will show. This would show a patient coming to you with a prominent winging of both scapulae. You have to always never forget facioscapulohumeral palsy. You have to know which muscles are atrophic by palpating the supraspinatus, the infraspinatus. You have to realize that there's a difference. You have to examine your patient well to rule out any neurologic deficiency. These are the types, and Ovid's MRI shows you a ganglion in the spinal glenoid region pressing on the infraspinatus. And this is why the patient has a paralysis of the infraspinatus, but not of the supraspinatus. You have to know, if you look at the upper arrow, this is the suprascapular notch. If you have an obstruction over there or any kinking, this will produce paralysis of the supraspinatus and infraspinatus. Keep this in mind. You have to know that the muscle most commonly torn to produce abnormality shown is innervated by the upper trunk. It's to tell you that C5, C6 is what has led to this. This nerve passes the scalenus nerve. It's the dorsal scapular nerve, which is, we've spoken so much about it, that it supplies the rhomboids major and minor. You have to know the dorsal scapular nerve. What does it supply? Supplies the levator scapulae, the rhomboids minor, and major. This you have to know. If you have a patient, they will give you Erb's palsy, and the patient they draw a picture like this, the waiter's hand, and this tells you it's a C5-6. It's an Erb's palsy. You can have a complete palsy, which has a very bad prognosis, while you can have a C8T1 palsy, which is known as Klumpke, and this also has a bad prognosis. This occurs from shoulder dystocia during delivery. What is the termination of each cord? You have to know. This is just to let you know that you should know what is the nerve supply. Okay, which nerve is formed by the posterior cord? This is very straightforward. It's the radial nerve. The nerve labeled E, which is musculocutaneous, is supplying the coracobrachialis, is known at the coracoid process, the origin. Name 3 nerves that arise from the medial cord. These are the lists. You have to know these. Responsible for skin sensation, you have to know about the medial antebrachial nerve, which is an extension of the nerve. One could be of the ulnar, one could be of the median, and the other musculocutaneous. The posterior cord, what does it supply? It supplies the upper subscapular, the thoracodorsal, and lower subscapular. So you have to know these. What nerve arises from the posterior cord between the upper and lower subscapular nerve? It's the thoracodorsal to the latissimus dorsi. The structure indicated by the arrow of MRI is innervated by what nerve? The lower subscapular nerve. So you have to know these. What is the innervation of the pectoralis major? You have to know these. Look it up. I'm showing you these so that it would appear in the recording. I don't want you not to have these. So I'm speaking very briefly. The clavicular head of the pectoralis major muscle is innervated by fibers from which nerve root? C5, C6. The coracoacromial ligament, superior anterior restraint in rotator cuff deficiencies, stitchal coracoacromial ligament. If this is cut, it will not prevent superior migration of the humerus. This is showing you, do not forget that the contribution of the deltoid to atlantoaxial joint instability. Over here, don't forget about the sternoclavicular dislocation. Don't forget that you can have tracheal obstruction. Don't forget that you can have vascular injuries in posterior sternoclavicular dislocations. Don't forget that you always need a vascular surgeon when you're removing this, because you can get massive bleeding from it. So don't forget this. Don't forget about the rotation, the retroversion of the humeral head with respect to the shaft. It's 20 to 30 degrees. Don't forget about retroversion of the glenoid, which is 5 degrees. These are the anatomy. You have to know these structures. These are the structures that stabilize the shoulder. You should know, many times we give a photograph like this, and we say, what is this structure, etc. You have to know that laterally it's the pectoralis major. In the center, it's latissimus dorsi, and then teres major. Don't forget these words. Don't forget that the supraspinatus and infraspinatus insert on these structures, the greater and lesser tuberosity, and are supplied by C5, C6. Why are shoulder dislocations most commonly posterior in seizures? This is a very important question. And electrical shocks. And the result is because the shoulder, when they have this electrical convulsion, is usually an internal rotation by the pectoralis major, latissimus dorsi, and subscapularis, and are stronger than that of external rotation. And they're always an internal rotation. Why? Because these structures are stronger. Therefore, the head of the humerus dislocates posteriorly. Now, لك بدي اسالك خالد عم تزهق وانا بقدر احكي لبكره على بكره. خالد الشباب كيف ماشي حالكم يا شباب؟
دكتور جون
ماشي الحال؟
عم نسمعك مش زهقانين الشباب يعني مبسوطين جدا وعم بيتابعوا كل
لا بكمل
ايوه كمل
يلا بعد عنا شوي لان حتى اعطيكم يلا حتى نخلص لهم الريفيو. طيب positive Gerbert lift test is the lift off test لما المريض بيكون عنده tear بالسبسكابيولاريس. إذا في خزق بالسبسكابيولاريس ما بيعود عندهم a force of internal rotation of the humerus, so they cannot lift the hand off the back against resistance. This is known as Gerber's test. Also, abdominal press test, I spoke to you. You have to pay attention to this. Shoulder stabilization, مش رح نروح له. Name the static dynamic restraints of the shoulder. You have to know that there are static, we spoke about them, the articular anatomy of how it's built up. حكيتكم عن اللابروم, حكيتكم عن الglenoid, how it's built up. So you include the glenoid, labrum together with the anatomy. وكنت قلت لكم على negative pressure يلي occurs in the first 30 degrees of abduction. Also, you have the capsule and you have the ligaments. We spoke about the glenohumeral ligaments, the superior, the middle, and the inferior. You have to think of this. The dynamic includes the rotator cuff, the biceps tendon, the long head, and the scapulothoracic motion. This shows you the glenohumeral ligaments, each one and its function. بدي منكم تطلعوا على السلايد وتحفظوا شو قايلين عنه. These are more diagrams of the superior, middle, and inferior glenohumeral ligaments, and each one is discussed separately. You have to review this. What limits flexion and external rotation of the shoulder? It's shoulder flexion and external rotation. The standard position for arthroscopy, and I'm not an arthroscopist, بس بقول لك إنه it's below the infraspinatus. How do you move the axillary nerve? هيدي كلها arthroscopic. You have to know about the quadrangular space of how the teres minor, the long head of the biceps, and the shaft of the humerus, plus the teres major, all form a quadrangular space. And you have to know that the posterior humeral circumflex artery together with the axillary nerve pass through this. You have to know about the triangular interval, and this is the radial and the profundobrachii artery pathway. These are questions we always ask. What is the interval for posterior approach to the shoulder? And you have to know this. I wouldn't go through it. Okay, why is a quadrangular space important? You have to know because you could damage the structures while doing surgery. You have to know which structure is in C. You have to know the anatomy. Okay, so this is it. Let me see if there's anything else I would like to say. This is showing you a patient who has been operated. He has nerve damage. So you have to pay attention of how you put your plate, where you put your plate. Don't forget you have many structures over there. You have the axillary nerve, which is present at the inferior aspect of the neck, of the scapula. You can always identify it by putting a finger and you see that it's tight. Don't forget that this exists and you can put your plate right on it and damage it. Don't forget the various structures as you see. What are the three portions of the axillary artery? It's a pure memory question. You have to know them. You have to play them. Now, this is Schuler's top 10 review course. He speaks about brachial plexus, data, dump, pre-clavicular branches of the long thoracic, dorsal scapula, suprascapular, and nerve to subclavius. You have to know these. The main blood supply to the humeral head is not the anterior humerus circumflex, it is the posterior humerus circumflex. In 62% and 38% only the anterior. This has to be changed. The suprascapular nerve under superior transverse scapular ligament, water over the edge, the spinal glenoid notch. I spoke to you so many times that will give you paralysis of either the infraspinatus or supraspinatus. Shoulder instability, VS, motion. Yeah, of course, the most important ligament is the inferior glenohumeral complex. Arterial bleeding from the release of the coracoacromial ligament, acromial branch of the thoracoacromial, do not release the rotator cuff deficiency. Quadrilangular space, you have to know it. Triangular interval, triangular space, and rotator cuff. You have to pay attention. I want to make sure that there's nothing else I have mentioned. These are all questions. I'm putting them for you that you can collect them and study them. By the way, if you're operating on the shaft of the humerus, where is the radial nerve? It's usually perforates the lateral intermuscular septum at the distance of 7.5 centimeters from the epicondyle and 13 centimeters from the posterior structures. Be careful. This is the level in which the radial nerve is. We asked this question because it's a must. Okay, so I'm doing this so that you'll finish and have this. I'm sorry, I'm going very quick because, first of all, I can no longer speak. I'm too tired. And there's something else. One question we like to ask you boys is, what four joints can produce septic arthritis from direct metaphyseal extension? Don't forget, it's the proximal femur, the distal fibula, the proximal humerus, and the radial head, and no other joint. I repeat, the proximal femur, the distal fibula, the proximal humerus, and the radial head. Don't forget about the carrying angle. If you look at the carrying angle, she had a fracture of the elbow. You see that it's more on the right side. Normally, it's 7 degrees. It's more in females. Don't forget that if you draw a line through the anterior margin of the humerus, distally, with the elbow flexed, it should pass through the central 1/3 of the capitellum. Okay, don't forget, if they put an X-ray like this, look at the head of the radius, like trauma and dislocation. But tell my friend, this is a malformed head, and it has been going on for years. It's not traumatic, and this in children, if the patient is symptomless, we don't do anything. Don't forget about the anatomy of the elbow. What are the stabilizers of the elbow? Don't forget, this is a question that we like to ask about the angle in which if you put screws through, won't disturb motion. So keep this in mind. Know about the muscles. Where does the radial nerve emerge? And then you have to know these. Don't forget, I show you the brachial plexus so many times. And there is a question we like to ask. If you're doing a kosher approach, a kosher lateral approach, how should you put the elbow? It should be in flexion and internal rotation. So don't forget this. Pronate the forearm and protect the posterior interosseous nerve. In the Henry approach, you do it in full supination. You supinate, so don't forget this. Genscher's arm and elbow, the primary restraint of the valgus elbow load, anterior bundle of the medial collateral ligament. This is well known. The anterior bundle. Lateral epicondylitis or tennis elbow is the extensor carpi radialis brevis. The anterior medial elbow arthroscopy portal medial antebrachial cutaneous, I don't know this, cross-sectional anatomy, kosher approach to the elbow, pronate and protect the posterior interosseous nerve. Now, what else can we do? Let me see if there's anything. What are the forearm compartments? You have to know that. You have to know the anatomy of the vessels. Let me see. I'm doing this so that they will appear on your recording so that you can study them. Okay? What nerve innervates the highlighted structure? The anterior interosseous nerve. This is the pronator quadratus. You have to know of how to draw median nerve between the flexor digitorum sublimis and profundus, the ulnar nerve between the flexor carpi ulnaris and flexor digitorum profundus, the Henry approach, proximal radius supinate, retraction on the brachial radialis, compression on the superficial radial nerve, and anatomy review. We went through them in detail. Okay, but I want them to come out. That's why I'm doing this, so that you will have them coming out. Okay, don't forget, I spoke very little about the foot. You have to work on it, but as we discuss the conditions, we will be discussing anatomy of the lower extremity in association with conditions. Okay, so don't forget these. Okay? Virginia is about fishy lamus طويل. Okay. You have to know the anatomy of the foot, يا جماعة. Don't forget this. عم بيطلعوا هول بالريكوردينج. Thank you very much. خالد. يا خالد إن شاء الله ما راح. يلا. The meeting has ended with me having no longer a voice.
دكتور جون
راح صوتي.
دكتور جون
خالد راح صوتي.
الله يحفظك ويعطيك العافيه. ايوه يعني شكرا لك بصراحه. very strong review course للابر لمب كامل وكل حاجه فيها. يعني هاي الصور الشباب موجودين ممكن تشوفهم. بيسلموا عليك.
هاي
خلاص بس يلا. تمام، وشكرا لك يا باشا. اي حاجه عاوزه تتكلم تضيف شيء؟
طيب ليك خالد، ما تنسى تلفن لي تحكيني بعد شوي.
خلاص بتلفن لك، انا بقعد معاهم نص ساعه ساعه وبعدين اتلفن لك. خلاص
لا تلفن لي بعد ساعه بكون ارتحت، يعني
ايوه خلاص.
بنحكي بعدين.
حاضر. يلا
يلا
يعطيك
باي.
العافيه، شكرا لك. يلا خلاص. قال اكون قد انا ارتحت شويه وصوتي رجع. لا الشيء اتصل اتصال.